HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
Today I'll be talking to Dr. Iestyn, who trained in emergency and hyperbaric medicine and is a current director of Hospital in the Home in Hobart, Tasmania. He also has an interest in chronic wound management and has been the medical lead for the wound clinic at the Royal Hobart Hospital since 2015. Now, Iestyn, I don't know about you, but when I trained in emergency, I don't ever recall an ED doctor saying, "Oh, cool, there's a patient in cubicle 5 with a chronic wound," and clicking on them to jump in and sort out the chronic wound. So how have you, as an ED doctor, developed an interest in chronic wounds?
That is an interesting question, because in ED, I am that person who gets quite excited by the chronic wounds, partly because no one else seems to know what to do with them. Well, I got interested in them because as part of my ED training, I did a term in hyperbaric medicine, which I thought would be an interesting thing to do. It's full of divers and there was no night shift, and it was a good chance to study for my fellowship exam. But I really did get sucked down that hyperbaric rabbit hole, and the area of need that I could see was for chronic wounds. They just seemed to be a black hole of need there. And so once I actually became an emergency physician, I went on to do a fellowship year in diving and hyperbaric medicine. And as part of that year, I did a lot of wound management and worked to break down some of the silos of wound management in southern Tasmania. And that's how I got involved in the wound clinic and in the sort of wound management system here in Tasmania. And that experience did make me realize that this is a highly neglected and yet quite significant part of medicine. And many of your listeners will have seen chronic wounds, and I can almost guarantee that they've had very, very little training in that skill set, and they rely on the nursing team to provide the dressings, who they are probably unaware of had almost as much training as they have on the management of chronic wounds. So it's one of those things. We waste vast amounts of money, a couple of % of the entire health budget of Australia, in our ignorance of managing chronic wounds.
In fact, I think I've got a statistic here that tells us it's close to 500,000 Australians currently living with a chronic wound that's costing the healthcare system around about $3 billion a year. But of course, that doesn't probably take into account the impact it has on the person themselves and the impact it probably has on the flow through of general practice and hospital care. And the AMA, in fact, they said if the government got serious and invested $23.4 million in the delivery of evidence-based wound care, they could save $203.4 million, which is pretty amazing, isn't it? And I think you're exactly right in terms of the level of training. Often in general practice, it does feel a little bit like the blind leading the blind in the management of wounds. And one of the things a first-term registrar will always struggle is, because they'll often have patients booked in with them because they can fit them in quickly, is wounds. And you'll get so many calls about, "I'm not sure what to do with this wound. Can you come and help me?" Because it's not really part of our training. So that's why we've got you here today, because you're going to give us Wound Care 101 in a crash course under 30 minutes. So we'll just get through some basics, but the basics will be a good start, particularly for all the GP registrars who are starting out. So I thought we might start with skin tears, because skin tears are pretty common. And I think if you saw a skin tear on the day it happened, that's one thing, but often with the difficulty getting a GP appointment, a patient might turn up a week or 2 weeks later. And as an aside, tell you, by the way, I had a skin tear, and you have a look at it and go, "Oh, what am I going to do with that now?" So talk us through a skin tear and how we might manage that best. And then we might get on to the skin tear that has sort of developed, not quite into a chronic ulcer, but it's on its way there.
Well, skin tears are very common, particularly as our population ages, their skin dries out, it becomes more fragile. If they're on steroids, it becomes more fragile. Any edema there makes that skin paper thin. Now, skin tears themselves, I have discovered, are actually relatively forgiving. And I think this is why we have neglected skin so much and we don't know what to do with chronic wounds, is because as an organ, it's about the most forgiving organ that we have. So if you've got a new skin tear, it depends a little bit on the size. I find, although there's a knee-jerk reaction in ED to refer some of the bigger ones to plastics, actually most of them can be managed relatively successfully with sort of fairly minimal resources, which might be of some reassurance, particularly to some of your more rural colleagues. The key thing with skin tears is to try and analgese them. I find that the lignocaine catheter gel works quite well. That adds a little bit of analgesia as well as making everything a bit slippery. And then you want to fold back the skin tear. You'll often see sort of purplish blood clot on the back of the skin tear, and you want to scrape that off. If that clot remains, it actually is going to devitalize the skin from sitting down on the wound bed, which hopefully is going to sort of revascularize. A good way of looking at it is it's a split skin graft that is still attached to you. The next thing you want to do once you've got rid of that clot, and I find the back of a metal forceps, just rubbing that across very gently and lifting that clot off is quite useful. You want to unfurl it because you don't want the edges to roll out. And you want to do that fairly gently. A little cotton bud or swab stick works quite well for that. Traditionally, at this point, you pull the thing really tight, covered it in 500 steri-strips going all over the place, and the thing went on to fail. The reason is that those steri-strips tend to trap moisture underneath them. They're very difficult to remove, and you tend to lift the skin flap. So the best thing you can do at this point is then hold it in place. Now, some of the silicone mesh dressings, of which I think Mepitel by Monlica is probably the most well-known, and ideally you want Mepitel 1 because it's only tacky on one side. You place that tacky side down and just drape it over the skin tear, and that's transparent. Moisture comes through it. It doesn't adhere to the skin tear, and it holds it nicely in place. And that then can be left for a week or potentially 2 weeks and just allow that skin tear to settle down.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
So when you say tacky, do you mean sticky?
It's sticky, but not adhesive.
Okay.
So it feels tacky. And if you pick up a piece of Mepitel or equivalent with gloves on, it will stick to you, which means the double-sided Mepitel is a bit of a pain. But it holds, if you add water to it, it will come off quite easily. But what it doesn't do is it doesn't adhere. So, adhesive tapes adhere to the skin. This is actually, if you soak it in, water, it will actually lift off quite easily. But in the meantime, it actually holds that quite firmly. And the other thing, it's not a jigsaw puzzle. It doesn't have to completely fit. You're allowed some missing bits. And, not all that skin flap is going to, become, a lot of it's going to devitalize, but it's probably donated a whole bunch of epithelial tissue that can grow from there.
What do we put on top of the Mepitel?
Mepitel on top of that. And then you want an absorbent pad. So certainly not a combine. You need something that locks the fluid away. We use Zechovit, but Mesorb or one of those absorbent pads over the top. For the smaller skin tears, certainly you can use the little border silicone dressings and do the same thing, but they're not transparent, and you actually want to put an arrow on to show the direction of removal. Personally, I like the Mepitel because it means that the secondary dressing, the absorbent dressing, can be removed and you can see what's going on. And then you can just leave it alone, potentially. And then you can bandage or hyperfix it. I mean, you can place Hyperfix on even the most delicate skin if you're prepared to remove it with gently or with appropriate adhesive removers.
Right. So what about the skin tear that's 2 weeks down the track and starting to look a bit manky?
The skin tear that looks a bit manky, and I had a horrible one of these last year that a GP asked me to have a look at. That patient had actually got a little bit drunk on Christmas Eve, fallen into a chair, and had a huge skin tear around her antecubital fossa. She'd gone to ED, they sent her to plastics, but she kept getting bumped off the emergency list, and 6 days later it looked a mess and they sent her home. What you want to do there is actually just remove all the devitalized tissue. If it's on an upper limb, it's going to be pretty forgiving. Again, I remove all the devitalized tissue. I'm down to whatever the base tissue is, and then I would just put a non-adherent dressing. I often use Mepitel again, which is quite expensive, but it can just be left alone, and that allows sort of granulation tissue to appear, and then the epithelial tissue to migrate in. And then I dress over that, and then I just keep an eye on it a couple of times a week.
6 days down the track or 2 weeks down the track, is it likely to have ooziness and be infected, or?
It's likely to ooze a little bit, which is why you want some kind of absorbent dressing. Plain foams also would work. Any of the silica border type foams would work. Just needs to not adhere and be absorbent. Now, if you're leaving it for any length of time, dressings like Gelinet or Bactigras, those very traditional Toolgart dressings, will dry out. And after a couple of days, you may well find that the granulation tissue has grown through the Bactigras or the Gelinet. So I really would steer away from those. But otherwise, other non-adherent dressings usually work quite well. Depends what you have access to. I'm kind of lucky in that we provide the dressings for free here out of the Tasmanian Health Service, including our community nursing teams, and that's not common practice.
Which I think is one of the things the AMA is alluding to, perhaps looking at how to fund that better.
Well, yeah, there is so much money to be saved in the long-term management of chronic wounds if we funded compression garments and dressings.
So in terms of the skin tear you're thinking it's looking a bit infected, what do you do with that?
So if it's looking infected, give it a clean. It's worthwhile. I mean, if there's surrounding cellulitis, you can put them on antibiotics and that will hopefully settle things down. If it's likely to look a little bit red anyway because it's inflamed.
Yeah.
So you need to make a decision about that. And antibiotics are cheap in comparison to the dressings. Often you've got a little bit of local infection. You've probably got a little bit of biofilm. So this is the bacterial film. It's a bit like the plaque on your teeth that forms on wounds very quickly. And antibiotics won't get to that because it's on the surface of the wound. There's no blood supply. And this is where your topical antimicrobial dressings are helpful. Some are cheaper than others. Very simple antimicrobial dressings like Inodine, which is an iodine-soaked kind of gauze, may well help there. Obviously, the more expensive dressings include things like silver. Antimicrobials like honey tend to make things very wet. And salt-based dressings just need to be changed quite often, but are quite cheap.
So that gives us our simple skin tear, our more manky skin tear. And now we're going to go to the chronic ulcer, which is, the one that we all kind of dread.
There is, I suppose, just going back to the skin tear thing, if they're on a lower limb, particularly an edematous one, then they're at high risk of becoming chronic wounds unless you manage the edema. And I suppose this is... Now, most chronic wounds that you're going to see are lower leg wounds. In fact, 70+% of chronic wounds are in the lower legs. There is some sort of classical textbook figures for those, which would suggest that 70% are venous leg ulcers, 10% are arterial ulcers, 10% are mixed arterial venous, and 10% are other. I'm not sure that those figures strictly apply to our modern multi-comorbid population, but what the key thing I'd like everyone to know is the dressings that you put on a lower leg wound are not the be all and end all. If you want to heal a difficult lower leg wound, you need to get somebody into some kind of compression garment. Now, there is a broad spectrum of compression therapy available. The things that you may have learned about in med school or vascular terms are the kind of 4-layer Charing Cross compression bandaging. Now, I've been running a wound clinic for the best part of 10 years, and I can think that we have maybe had 1 or 2 patients a year out of the 120, 150 new patients I see in that kind of dressing. No one likes it. It's very poorly tolerated. And we take the approach that some compression is better than no compression. And there's lots of different garments and systems out there that we can gently introduce compression to somebody to try and reduce their edema. Now, obviously, you need to make sure it's safe to do so. And probably the greatest harm that we do in chronic wounds is our fear of making a limb ischemic by putting it into compression because they have arterial insufficiency. In my experience, very few patients do, but I probably get a slightly warped view of the patients I see. But the biggest thing that you can do is do some vascular studies, and the easiest thing for GPs to do is get an arterial duplex ultrasound. And you combine that with your sort of clinical examination. What's the capillary refill like? Do they have warm limbs? Most of your elderly patients, you probably can't feel their pulses, but if you can feel their pulses, they've probably got good circulation. But the arterial duplex ultrasound, essentially our vascular surgeons are not very interested in anybody with less than a 75% stenosis. And 50 to 75%, we regularly compress those patients if we're happy with their, other features.
Most ulcers are going to probably be venous.
Or they're going to be, I was going to get to that. They're going to be edema related, whether that be venous edema, whether that be lymphedema, dependent edema from your heart failure.
But the take-home message really is they're very unlikely to be due to arterial insufficiency, which is the thing we're all worried about.
That is the thing we're worried about.
I was going to say, so it's quite easy for most patients in the community to get access for a the type of scan, the arterial duplex ultrasound. Possibly a little bit harder for patients in a residential aged care facility, but we can use our clinical acumen to assess those features.
So you can definitely use your clinical acumen. The other thing you can do as a bedside test is an ankle brachial pressure index. Now, that's best done with a manual blood pressure cuff and a small Doppler ultrasound. And that's what we do on most of our patients in clinic. Now, if you get the waveform, you can bill Medicare for it. It probably is still not worthwhile, but that can be done at the bedside. Absolutely. Yeah. The other thing that, if you think about it logically, any part of you that's made ischemic is going to hurt. So the patient, to actually cause harm, the patient's got to not feel the limb, and we wouldn't put compression on somebody with a paresthetic limb because there are problems with pressure areas and injuries from compression, and they've got to have no way of taking it off or asking for help to take it off. And that may occur in some demented patients, but if your patient can feel pain and is in a position to do something about it, then we can apply some compression. Now, we seem to apply TED stockings, for instance, to everybody who comes into hospital and don't even think about this. Now, that's definitely very much the lower end of compression therapy, but I do have some of my frail patients who've had venous leg ulcers, or I'm treating for venous leg ulcers, in that level of compression, which is about 10 millimeters of mercury. Mm-hmm. Normally, I'm aiming for somewhere around about 20 to 25 millimeters of mercury in most patients, which can be achieved with some of the Sutherland products, which is an Australian company that makes a tubular form, and that can be achieved with 3 layers of tubular form of differing lengths, or their graduated shaped tubular form. And that's a very cheap and cost-effective way of trialing someone.
That sounds so much better than the cumbersome bandaging that I remember being taught that you spoke about earlier. So that's terrific.
Well, that's a very simple compression type system, which is relatively cheap. It doesn't last that long, but it's a good way to introduce somebody with some degree of flexibility. Ultimately, I'll be aiming to get them into a compression stocking, which again is quite cost effective. Compression stockings are probably somewhere between $50 and $100 a pair. They usually need 2 pairs, one to wear, one to wash. And those last anywhere between 4 and 6 months, depending how active the patient is. And they come in 3 different classifications generally. Class 1 is sort of 15 to 20 millimeters of mercury. Class 2 is 20 to 30. And class 3 is above 30. I have almost no patients in class 3, and I have difficulty getting all those on myself. So my younger patients, I try and put into a class 2 stocking, and my older patients are class 1. And that usually helps things along.
So as you said, some compression is better than no compression.
Absolutely. And those can be bought on, the internet or through a chemist. Some may well need a prescription for a doctor, but once you've got your vascular studies, you can try that. And then they're a pair of socks. They're mostly foolproof to put on. For patients with big ulcers, they probably need bandaging. And our usual preferred type of bandaging is the 2-layer cohesive bandaging. The one we use is called Coban 2 or Coban 2 Light. Most people I will put into the light version first and then increase up to the full Coban. Mm-hmm. That for the patients is going to be $50 per application. Now, what you have to realize is that we can probably get an ulcer healed with standard of care treatment, particularly if it's not very big, within a couple of months. And you will all have patients who are coming back to your practice 3 times a week indefinitely. And, there's a lot of patients we get healed up quite quickly once we get them into sort of standard of care treatment. Obviously, you have to have a nursing team that can apply that, and that may be difficult. So the other option, which is expensive outlay, but really, really effective and allows a bit of patient independence and adjustability for the days it's too tight, is something called compression wrap. And they end up being about, for a foot and lower calf wrap, somewhere in the region of $300 to $400. But we can basically eke a year out of that if they're careful with it. And so if you're looking at what would otherwise be a weekly or twice weekly change of a bandage at $50 a go, you can see that that becomes very cost effective. And many patients you put into a compression bandage will get fed up with it. It's too hot. They cut it off and you start again. With a wrap, they can decide it's too tight and loosen it, or take it off and put it back on. Not that I want them to do that, but it adds a great deal of flexibility. And over a year is probably the most cost-effective compression method. And it's easy to get on, and almost anyone can put it on with about 2 minutes on a YouTube video. So they're very difficult to mess up. And these things are great for just lower leg ulcers. Now, your lower leg ulcer may be purely venous in origin, but a lot of the multi-comorbid elderly patients I see today probably have an element of venous disease. They've had hip and knee replacements. They're overweight. So there's actually an element of lymphedema there. They've probably also got heart failure. So there's an element of heart failure. And no matter how much you diurese it, you will never get enough fluid out and have functioning kidneys and them being able to stand up. And then, of course, their skin gets looser. So there's a degree of dependent edema in all of that. And so the actual diagnosis probably doesn't matter. The other thing that is worth thinking about is that although venous leg ulcers, the textbooks would suggest they're painless. That is not my experience. And at least a third of my patients that I see in clinic, again, I realize that they are a slightly selected group, have pain, and that comes, and the description of that pain is sort of fairly classically neuropathic. Mm-hmm. Now, it's burning, it's stabbing, it's like electric shocks. Yeah. It's often worse when, the dressing's down. I mean, you've got a great big superficial wound and a lot of exposed nerve endings. Now, until that pain is managed, you're not actually going to be able to, do any significant treatment. You're certainly not going to be able to put them into compression. Now, I find some of the neuropathic pain meds work quite well. If it's mostly the pains at night, I use things like Endep. If the pain is through the day, I often put them on a dose of Lyrica, and I would expect to titrate that up, and then as the wound heals, titrate it off, titrate it down and get them off it. And
Yep.
as the wound heals, I generally get almost all my patients off the neuropathic pain meds, and it enables me to put them into compression.
All right, so maybe just step us through from first point of contact. You see a venous ulcer. It's a little bit sloughy looking. There's a little bit of discharge happening there, but it's the first time you've seen them. They've probably had it for 6 to 8 weeks, maybe been trying to heal it at home, but it just hasn't.
Yeah.
And they finally come in and they're in your treatment room. Just step us through how to do the assessment and then how to start with the dressing of choice. We've talked about the pain meds, but the ultimate aim, I guess, is to get in compression. Just talk us through perhaps the steps.
I'll talk you through that. Now, I suspect this is something that you want to have an idea about and get probably your community nursing team involved in this. That's going to be better than your practice nurses. Patients come into my clinic and they are rarely there for less than an hour. And for an initial assessment, they may be there for an hour and a half. This is hugely time consuming and way beyond sort of any GP appointment. But they come into clinic. I gain find out about the wound, when it happened, how it happened, has it happened before, is this a recurrence, get the general medical history. I suppose key things I'm looking for there is, are there any signs of arterial type disease, or has this come about through a venous edematous process? Is there any chance that this could be a malignancy or some weird infection? And going forward, if the wound doesn't do what I expect it to do, I biopsy them, both for histology and for microbiology. I then concentrate on their pain. What's that like? Are we going to be able to do anything with this wound until we've managed the pain? As far as the wound is concerned, we will clean the legs with a soap-free wash to get rid of a lot of the debris. And the wound itself, we generally cover in local anesthetic, so EMLA, topical local anesthetic, leave it for 20 minutes, and then I do a sharp debridement of the wound. These wounds develop a lot of slough, a lot of biofilm, a lot of dressing products. Alginates like Caltastat are the worst. The amount of wounds I've just pulled 6 months of dressing product that's slowly built up is unbelievable. And then I basically use a disposable metal curette and take it off. Now, that is obviously a fairly specialized thing, but on a day-to-day basis, nursing teams can use metal forceps, or they can use a wound debridement pad. Now, they're about $15 each. They look like a dishwashing cloth. They're relatively good at removing the debris. And removing that debris is going to give the wound a better chance of healing. In the same way that you clean your teeth every day, otherwise you get gum disease, the same thing is happening on that wound. So it's actually a really good thing to do. At present, we're not really resourced to be able to do that as a health system, but that would be the gold standard thing to do. I would also, very few of my patients come with an arterial duplex ultrasound. So we would also do an ankle brachial pressure index at this point. Now, we often put light compression on people with what was seen as a low arterial ankle brachial pressure index. And I wouldn't expect everyone to do that, but we're doing that vascular assessment. And then I will apply a dressing that may well manage any bacteria that are there, particularly if they're vulnerable or immunosuppressed, the diabetics. So we'll use antimicrobial dressings. We will use dressings that are not going to adhere and are going to lock away a lot of moisture. We don't want the wound too dry. We don't want it too wet. We have to find that Goldilocks, window where we've got moist wound healing, but a lot of the excess moisture is locked away, particularly if we then apply compression and we essentially wring that wound out. I will then come up with a compression plan that takes into account what's going to optimally work for the patient, what their nursing team can actually apply. So I need to know where they live, who their nursing team are, what their skills are, what products they've got. I'm lucky in that most of our nursing teams are government Tasmanian Health Service, and they have access to a lot of stuff for free, but that's not the case for all my patients. And so I will be deciding, how much it's going to cost them and what works best for them.
Yeah.
And that's the basic plan. And then I write a plan. The community nursing team ideally execute that plan and give us feedback. And we see the patient somewhere between 6 to 12 weeks later to review the plan. Usually for a new patient, I aim to see them at about 6 weeks later. I have a lot of patients with very recalcitrant ulcers that are probably never going to heal, that we do a lot of sort of ongoing debridement on, and I may see them on a 3 to 6 monthly basis, just to mostly debulk all the bacteria that are building up there.
Right. So that's sort of, I guess, where we might have to send someone if we're not winning with an ulcer. If we see a patient with a relatively small venous ulcer with, classic associated morbidities that you're talking about, some heart failure, some lymphedema, someone who perhaps hasn't got great mobility, and we want to start out getting that right so we don't have to send them to you. Talk us through how we should approach that.
The best way to approach that is to know what the capability of your community nursing team are, because they're going to be able to, this is often quite time consuming. Although they may charge, they may well have access to products that you don't have in your general practice. So you want to contact them. You want to arrange for some vascular studies. And then if the vascular studies are, good enough, there's not too much stenosis there. There's no signs of ischemia or, significant, flow defects. You can then speak to your community nursing team about putting the patient into some kind of compression. And they're going to need the go-ahead from the medical practitioner to do that. Depends on the nursing team, but that's the collaborative bit. My experience with even our nursing teams, who I think are quite good, they're very rarely going to instigate treatment on their own or feel, authorized to do so. They're actually going to need a doctor's prescription essentially to put them into some kind of compression.
So I guess what I'm really hearing from you is compression, 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 or you're not going to win with a venous ulcer.
I mean, many of them do slowly heal up, and you get those patients who've slowly healed up over 18 months, but you probably could have reduced that to 6 weeks if you had applied appropriate compression. I mean, I had not so long ago, I had a 45-year-old woman who was a little bit overweight. She had had a venous leg ulcer for 9 years, seeing her GP multiple times a week. She got referred by a different specialist to come to wound clinic, and with standard of care treatment, we got her healed up in 8 weeks. So, that can be the difference. Obviously easier with younger people, but that's what we're looking at. And there's a huge quality of life, implications for that. The other thing is, once you've got your venous leg ulcer healed up, they need to be in compression stockings more often than not, because it's really common for us to see somebody we've healed up, we've put them in compression stockings, they disappear, and they rock up 3 years later, they come out of the compression stocking, someone's told them they don't need to wear them anymore, and all of those venous problems haven't gone away. And even if they've had, say, a venous intervention from a vascular surgeon, the 10-year success rate of those interventions is about 50%. So they will often relapse. So most of our patients, we at least tell them that they're probably going to be in compression indefinitely. That doesn't mean they necessarily have to wear it every day. And, in hot parts of Australia, that's probably not practical. And, people want to wear skirts and things like that, and that's fine, but they should be wearing them more often than not, even once they're healed.
And I suppose it's that thing of when you're sitting down, elevate your legs and just be mindful of those kind of things as well.
Elevating your legs is good. Walking is good. The amount of patients I see, I've been told to sit around and and elevate my legs, but actually walking the ankle, if they've got good ankle mobility, the muscle pump is very good at reducing that edema. The worst thing you can do is sit or stand for prolonged periods of time.
Well, I think that's given us a really good insight into Wound Care 101. I'm sure you could talk for hours and hours about all the intricacies of specific nuances, but that's at least what I think is a really good outline of an approach to seeing the kind of wounds that we see quite frequently in general practice. And, we can only hope that one day there will be some adequate funding allocated to wound care, so that it can certainly be more efficient in general practice and accessing, community nursing to do the hard work sort of in between coming and seeing us. So any last final take-home tips or tricks that you'd like to share with our listeners, Iestyn?
I think probably the most useful document you could get on this is Wounds Australia actually do a flowchart for lower leg ulcers as to
right.
how to, you may have to pay for it, maybe behind a paywall. It's only about $5, but that is probably a very useful document for everyone to see.
We'll make sure we include a link to that. I'm sure that within most practices, they could manage to get one of those and at least have them, one up in the treatment room so people can see it. Thanks so much for your time again, Iestyn, and we'll be hassling you, I'm sure, for something else in the future.
Thank you very much.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.